Welcome, everybody. Thank you guys so much for joining Epilepsy EXPO here online this year. We missed you guys in person, but thank you so much for joining virtually. My name is Rachel Edasami. I am the program coordinator for an organization called Epilepsy Support Network of Orange County. We are here for everyone, not just Orange County. We are a local organization, but our number is always available. We work very closely with CHOC Hospital and the amazing doctors there like Dr. Steenari. We have lots of programs that we offer, but I will just go ahead and link our information down, our website down in the chat section and introduce the lovely Dr. Steenari. She is a CHOC epileptologist and she speaks with us often, and every single time I learn something new. She has a sweet and compassionate heart, and I am very proud that we get to work with amazing doctors like this, and I'm excited to hear what she has for us today.
Thank you, Rachel. So yeah, happy Monday to everybody. This is super exciting. Unfortunately, we missed Disneyland this year, but hopefully next year, right? This is wonderful opportunity to connect with everybody online. So thank you for joining. I am trying to share my screen so I can, whoop, sorry. There we go. Is that better? Perfect. So my topic today is, let's start from the basics, Epilepsy 101. I think we thought that this is a good start for these wonderful 2 days, kind of getting the groundwork or the base of what are we talking about when we're talking about seizures and epilepsy. What is a seizure and what's epilepsy, and when do you mean when you talk about, what do you mean when you talk about one word or the other? So what is a seizure? So it is something that happens transiently, and the signs and symptoms can be depending on where in the brain they start from, but it's an abnormal, excessive, and often too synchronous neuronal activity in the brain. And as I mentioned, seizures can look in multiple different ways, and I'm going to go into detail about this a little bit later on, because that kind of is part of the exciting detective work as what we epileptologists have when we're trying to figure out what's going on, which kind of situation happens first, so then we can figure out where the seizure is coming from. Seizure by itself it's not a disease. It's always a symptom of something underlying in the brain that is affecting the brain. So for example, I always use fever as a kind of a similar symptom. So you can have fever from multiple different underlying causes. So seizure also can be multiple underlying causes of the brain. When we start thinking about if somebody had a seizure, we first need to figure out if we're actually talking about epileptic seizure, or could it be something else? So that's kind of our first job as physicians and as neurologists and epilepsy doctors, to figure out what are we talking about? What was that event that your child had? Because it can be multiple different things. It doesn't always have to be a seizure. It can also be a fainting episode or syncope. It can be just too low blood glucose level and your child behaves interestingly. It can be a migraine. There's, for example, confusional migraine that can look very similar to certain seizure types. It can be a vascular condition. For example, some of our patients, they have also vascular malformations, and they can have actually transient ischemic attacks that can look like seizures. It can be sleep disorder. Many seizures happen at night, but also there are multiple sleep disorders that can look kind of similar to seizures. So we'll have to kind of figure out that as well. It can be movement disorder. So many times we see kids with different sudden movements that could be, for example, tics, motor tics. We have several of our patients who have increased tone, they have spasticity, dystonia. So many of those movements, the abnormal movements are not always seizures. Little babies, sometimes just reflux can cause episodes that are intermittent that can look like seizures, like back arching, stiffening, turning purple, stopping breathing, and it's not always a seizure. And then there's also some psychiatric conditions or psychological conditions where the events look like epileptic seizures, but they're something else. Panic attacks can look like seizures. On the other hand, I've had also several patients who've been treated for panic attacks for years without being successful, and then we'll figure out, they are actually temporal lobe seizures. So that's kind of the purpose of this, that your doctor should really kind of pay attention what happened and what is it, because then when we know what it is, then we can treat it appropriately. So when we will figure out that, okay, that this most likely was a seizure, we'll do some battery of tests for kind of figuring out why, and maybe is there a risk for more seizures in the future. So typically kind of our basic tests include EEG, which is one of these tests where we put stickers or little electrodes on the brain. And the routine EEG lasts typically about an hour. We want some awake time and we want some sleep time during that time. And then we'll measure the electrical activity of the brain with those electrodes. And sometimes we'll see if there's a certain area that's either not functioning correctly, so that we see slowing. Sometimes we can see what we call epileptic discharges, so little sparks or sign of irritability in one focal area. Or sometimes we see what we call generalized discharges, those discharges that kind of spark throughout the whole brain at the same time. We'll do imaging study. We'll do, sometimes when you go to emergency department first time after a seizure, they'll do a head CT just to rule out big things like bleeds and fractures and big masses. But we also want a magnetic resonance imaging to look in more detail of that brain structure, because sometimes there can be a structural abnormality causing those seizures. For example, here on the bottom of the page, I have a screenshot of an MRI. And in that MRI, this particular patient had a focal cortical dysplasia that was the cause for the seizures. We'll typically make some initial blood tests to make sure that there's no acute changes like electrolyte abnormalities causing seizures, or low glucose, or difficulties with calcium, signs of infection. So if a child is febrile when they come in with a seizure, we'll look for infectious cause as well, for example, encephalitis, and we might want to do a spinal tap or lumbar puncture to evaluate for that. Later down the line, we might want to do a lumbar puncture even if your child is not sick, just to look for other metabolic conditions. And those tests are a little bit more fine detail. So seizure is not just the one that you see on the TV where somebody's unconscious and shaking both sides and drooling and not responding and kind of falling to the ground. It can be multiple different things. It can be just movement on the face or one side of the body, face, arm, and leg. It can be just a plank stare. It can be sudden drop or fall to the ground, and that's it. Kid gets up and continues to walk. In fact, it can be a very brief muscle spasm or kind of a jerk. It can be repeating movements like blinking of the eyes, pulling, picking of the clothes, lip smacking or chewing movements. It can be visual symptoms. It can be a smell, multiple different things. Motor signs are the kind of the easiest signs notice that, oh, that's odd, something is going on. What is that? When a child has movements that are not typical for the child. Typically, they're either the movement is tonic, so stiff, or it can be clonic, like rhythmic jerking. And depending on where in the primary motor area the seizure is coming from, it can be just the face jerking, pulling, or arm and leg including as well. Sometimes we do see, after the seizure, we see weakness on that side as well. So that can be a key clue for us later on that, maybe the seizure included the motor area. There can be eye movements, so just kind of the child's eyes get stuck to one side, or there can be nystagmus, that movement is kind of that rapid rhythmic jerking to one side, or it can be eye blinking, and it can be also just one side eye blinking, which is kind of an interesting look. Can be mouth or tongue movements, can be a lot of drooling, a lot of multiple different things. It can be just all of a sudden, typically at night, frontal lobe seizures, we call them hyperkinetic. So rapid movements, kicking, spinning, doing a lot of rapid movements, and then all of a sudden stop. So it doesn't have to be always organized and rhythmic jerking. It can be also kind of very complex motor sequence. Sometimes if the speech area is affected, the kids can't talk. I've very commonly been asked about gelastic seizure, like my child has these periods of laughing. Are they having gelastic seizures? So the pure gelastic seizure, laughing seizures, they are caused by hypothalamic hamartoma. That's a kind of a tumor in the hypothalamus. It's very rare. It's most commonly not that. But we'll do our evaluation. Sometimes some kids or adults with temporal or frontal lobe seizures can have this kind of weird laughter associated with their seizures as well. And then depending where in the brain, in the sensory areas the seizure is coming from, the child can have symptoms from different sensory systems. They can just complain that, how I hear things, it changes, or have auditory hallucinations, or hear things that others don't hear. They can have a different smell. They can have a taste associated to the seizure. Visual symptoms, like I've had some kids who have quite complex kind of visual hallucinations as part of their seizures as well. Or sensory, like tingling, numbness, pain even. And that kind of gives us clues on where the seizure might be starting from. So I have a few pages of like very complicated lists, but what I wanted to point out with these lists is we love asking questions about what happened. No, what did you see first? What was the first thing that you noticed when your child had a seizure? Sometimes it's difficult to remember what happened first, or were the eyes open or closed. I don't know, I was panicking, like I was just calling 911, I don't know what happened first. But if we can tease out the kind of sequence of the symptoms, or which symptoms were included during a seizure, that can then already point us to, maybe these seizures started from temporal lobe, for example. Or, that's interesting. Even though in the end the seizure was the big generalized tonic-clonic unconscious, blue, drooling, and tired afterwards. But in the beginning, the child came to me, was not able to talk. His eyes went to one side and got stuck. And then he started picking things. And then he went to the big seizure. So that tells us, there might be a focal onset. And that then kind of gives us more insight of what to do, medication options, imaging, and all that stuff. So we love playing detectives and kind of trying to find some of these subtle signs. I'm just going to point out a few things like postictal nose wipe. So that's why we love asking you, can you please videotape the seizure for me? So then I can see what happens. Because, for example, this postictal nose wipe, so child has a seizure and then seizure stops, and then they kind of wipe their nose. And if this happens after each seizure, that can point us out, is it the left or the right hand that the child wipes the nose with? And it's often kind of the same side. So that's what ipsilateral means. Ipsilateral means the same side where the seizure is coming from, the same hand is used for the nose wipe. So there are some very, very cool and interesting symptoms that can give us clues on where the seizures are coming from. And then that might help us to look for the imaging, the MRI, the magnetic resonance imaging with a magnifying glass. Like, I think this child has seizures from right temporal lobe. Let's look at the right temporal lobe on a big screen to make sure that there's nothing structural that can cause these seizures. We love to put things in boxes just because it kind of gives us information and some expectation what might happen in the future. Or it can also give us clues on, should I put this child on medication, or what kind of medication should I put this child on? Or, you know what, let's just wait for a little bit and see how things evolve. So the first kind of big categories that we like doing is we try to figure out if a seizure that the child had, if it's a generalized seizure or if it's a focal onset seizure. And this is the old classification that was done in 2010. I'm going to show you the new one. It's similar and not quite, but I think the main big thing is it a generalized seizure, which means that the whole brain at the same time the seizure starts, nothing is one location originating, everything, the whole brain starts at the same time and stops at the same time. If it's a focal onset seizure, the seizure starts from one area, and then depending on which area, you can have multiple different symptoms from it. And as I said, the treatment is different. This is the latest classification. Again, same thing. Is it generalized onset or focal onset? They have further divided this to, is the awareness there the whole time period of the seizure, or is the awareness impaired during the seizure? If you heard the older words of complex partial epilepsy, for example, you're like, what's complex? What's partial? So what it means, what the complex partial means is the person who had the seizure had impaired awareness during the seizure. That's the complex part of it. So that's why they changed these words, because it was felt like complex is just a complex word. It doesn't tell us anything, but if we say impaired awareness, everybody knows that, oh, somebody's not fully themselves throughout the seizure. And then we further kind of divide it to motor onset or non-motor onset and so forth. These are more pictures of the same thing, just depending. Some people learn by words and some people learn by pictures. I learn by pictures and colors. So I just liked adding this in here. And then, so the complex partial or simple partial seizures and generalized seizures, that was the old classification, and that was there for 35 years. So many of us like still using the older words. At one point there was words like just cognitive, but that went way quickly. So that's not there anymore. So again, as I already mentioned, knowing the seizure type, is it focal onset or is it generalized? That helps us making the decision on what to do. Do we need imaging right away? Do we put somebody on medication right away? And so forth. And then some medications can worsen the generalized seizures. So it's very important not to use the wrong type of medication. And then from there, when we have classified the seizure, then we'll go to the next step. Could this be part of some type of epilepsy syndrome that we know? And when we can kind of put the history, the seizure type, maybe the EEG findings, and developmental history into a nice box and correlate that with some known epilepsy syndrome, then that helps us tell you, you know what? Your child has very high chance that he or she will grow out of the seizures. We might even not need medications, or you know what? This is very serious. We have to take this and be very aggressive with the treatment. We know that the outcome is very poor. Let's just start working. Let's do our best. Let's be quick. And then we can give you support as we go along. So when we can put symptoms and parts of the history and then EEG and all that into a epilepsy syndrome, that's very, very helpful for us and for you to know what to expect in the future. So I mix words like epilepsy and seizures all the time. So seizure, it's that sudden change on the brain activity, to synchronized activity of the brain, and you have symptoms based on where the seizure is starting from. So that's a seizure. But when do we talk about epilepsy? So what epilepsy is, it's a very simple definition. If you've had 2 unprovoked seizures over 24 hours apart, that's called epilepsy. So what unprovoked is, for example, if you have a little 1-year-old who's febrile and has a seizure during fever, then that's provoked, fever-provoked seizure. But if there's no provoking factors found, then we talk about unprovoked seizure. And then if your child has had 2 or more over 24 hours apart, then that kind of qualifies for the diagnosis of epilepsy. Or if you have 1 unprovoked seizure, and then we'll do the evaluation as I discussed previously, EEGs, MRIs, and so forth. We'll find some very typical EEG finding that we know that particular person has over 60% chance of having more seizures. We can then qualify that patient as being epileptic already. Or sometimes we make a diagnosis of epilepsy syndrome very early on. For example, there are some genetic mutations known to be associated with particular epilepsy syndromes. I'm just gonna, pull DRAVET syndrome out of the hat because I think many people have heard about that word. So it's a mutation, most commonly in SCN1A mutation. There's a few others as well. But so if you have a child who has that, or if you have, right, so if you have a child who has 1 seizure or has had genetic testing from other problems, and we find a gene mutation that's associated with particular epilepsy syndrome, then we can make that diagnosis already without needing the two seizures over 24 hours apart. So when do we start a child on a medication? When I was doing my training years ago, my mentor said, "Oh, everybody gets 1 seizure for free." So typically we don't start a medication after 1 seizure, unless what I mentioned previously, if there's a very abnormal EEG that we know that the risk for seizures is very high. But if if somebody has had 2 or more seizures, then we're like, you know what, now we know that the chances of the 3rd and 4th seizure it's much higher, 70-80%. Let's put you on a medication that prevents further seizures from happening. So the goal for that is that we completely control the seizures, because that's the way to allow the best growth and development possible. And we try to be making the diagnosis the best in the beginning, so we can pick the right medication and kind of give your child the best chance. And obviously, we don't want to use huge amount of medication if it's not necessary, because the higher the dose, the higher chances for side effects. So how successful are we with that? So we often kind of go back to this paper. I can't believe it's already 20 years ago, from Juan and Brody. And this has been repeated since, and the numbers still look about the same. So when we pick the right medication for the right type of seizures, and with an appropriate good dose, not like a little sprinkle, but a good dose, the chances for seizure freedom on that first medication is about 60%, 60-70%. So it's great, but there's still a big chunk of kids and adults who continue to have seizures despite on being on appropriate medication on a good dosing. Sometimes we'll have to add a second medication to that to control the seizures. But it doesn't mean that, then everybody's controlled. To that leftover 30-40% that were not controlled, only about 10% of those people reach complete control of the seizures after the second medication is added. If we have to add a third or fourth, the chances of the pie just gets smaller and smaller and smaller. And sometimes I see kids with 7 anti-epileptic medications, and I'm like, guys, it's not like if you're taking 30 or if you're taking all the medications that there is on market that you're going to be seizure free. Obviously, that's not working. Then we'll have to see if there's anything else that we can do for you. So about 30%, 25-30% of the patients have what we call pharmaco-resistant epilepsy. So despite being on 2 or more medications, you continue to have seizures. And this is the situation when you want to see an epilepsy specialist. Before I go into that, I'm gonna go back a little bit, because that's kind of one of the first questions that parents ask me. Okay, so doc, we take this medication and then he's gonna be fixed, right? So what's the expectation? What is the chances that your child, if they've had seizures and then they're diagnosed with epilepsy, what is the chances for growing out of it, or being exactly cured, if you will. So there are some features in the history that are towards yes, most likely your child will grow out of these seizures. For example, if there's normal kind of cognitive state, regular classes in school, the neurological exam is normal, so there's no kind of focal findings in the exam when we do the motor test and hit the tendons with the reflex hammer and look into the eyes and so forth. The seizure burden, so what that means is how many seizures does one particular person have. So if there's been 3 lifetime seizures and everything else is normal, there's a high chance that hopefully you grow out of the seizures. And we know that if the epilepsy or if the first seizures start way before puberty, then you have much higher chance of kind of growing out of those seizures and that epilepsy. If your teenager, 15-year-old, who is in good puberty or looking like an adult already, then the chances of the seizures, seizure freedom is much lower. So what I typically tell the parents, like, so, this is what it is. Things look very good. What we'll do is we'll start medication. We'll continue the treatment for 2 years. And if there has been no seizures during that time, we'll repeat EEG often before the 2-year mark, but at least by the 2-year mark. And if the EEG is normal, then your child has very high chance of not having any further seizures, and we can wean the medication off. Sometimes everything kind of points to yes, things look good, there has been no seizures, the EEG is normal, medication doses have been pretty low, let's wean the medications off. If the seizures come back, we'll restart the medications, and then we'll start the 2-year clock again. When is it considered that the epilepsy is resolved? It's if you haven't had any seizures for 10 years, and of those 10 years, you've been off medications at least 5. So it's a long time. So you carry that epilepsy diagnosis often throughout your childhood if you get it. But it's still not forever. So if the last seizure is, for example, at age 7, and you wean off medications at age 9, so then by 14, 15, we can say, your epilepsy has resolved. So now I'm going to go back to when to see epilepsy specialists. So first medication, seizures continued, second medication was added, and still having seizures, then that's the time to see an epilepsy specialist, because then we want to see if there's anything else that we can do. Because as I showed you before, if we just keep on piling those medications, 3rd or 4th or 5th medication, considering that all those medications are appropriate to that epilepsy type, we know that our chances of seizure freedom is only a few percent. So of these things that we can offer, epilepsy surgery has the highest chance for seizure freedom, and sometimes even weaning off the medications when seizures are refractory. Now, epilepsy surgery or the curative epilepsy surgery, there needs to be a lesion or a location where the seizures are starting from, focal onset seizures. And then we'll do a pretty big evaluation for that and work up for that. But we have several patients that have gone through this kind of pathway, and we're able to find the reason where the seizures are starting and why that's happening, removing that area. The kids become seizure free, and sometimes, not always, but sometimes we're able to wean the medications off. Other things than medications are, for example, vagal nerve stimulator that I like to use a lot on our refractory kids because it doesn't have the same side effects as the medication. So the goal of the anti-seizure medications is the brain. So there's always some effects that the medications have. Obviously, we'll try to pick the one that has the least amount of side effects to your child. But there is always some kind of an effect. So some kids are very sensitive to those side effects. So I like the vagal nerve stimulator because that doesn't cause tiredness or constipation or insomnia or sleeping too much or tummy pains or whatnot, or rashes. And it's pretty actually effective controlling the seizures. It's not curative, but it can be a significant improvement on the seizure burden. We use diets quite a bit. So ketogenic diets is the kind of the tightest diet that we use as a medication, but we have multiple kind of different layers of it. Modified Atkins diet is kind of the easiest to do. So many of my teenage patients are on modified Atkins diet. We'll just give them a carb gram amount per day, and they use their app and kind of choose their foods accordingly, and they're typically pretty independent on doing that. And then there's multiple kind of different ratios of ketogenic diet. There's low glycemic index diet and so forth that we use based on what's going on with the family. Does the child have a feeding tube, or does the child eat by mouth only, and whatnot? So there's multiple different ways of using the diet. Then there's kind of very new things that are coming out. For example, deep brain stimulator that we're kind of starting to use for refractory epilepsy. And there's RNS that's kind of a focal, you could consider like a pacemaker. So we put electrodes right on where the seizures are starting, and then the device can actually measure or detect the seizure almost starting, and gives a little focal zap, if you will, to stop that seizure. So that's been quite effective as well. So there's a lot of new interesting technology that we can also consider if your child is not an resective epilepsy surgery candidate. So I wanted to give a little kind of a window to our thought process on when we see your child for seizures. We'll, go through the steps of, are we sure it's a seizure? What else is going on in the child's life? What age is the child? We have a lot of just little NICU babies or young infants that start having seizures, or babies, or toddlers, or childhood, or school age, or teenagers. And then based on that age range and what else we find on our workup, we can figure out, oh, this is part of this particular epilepsy syndrome. Now we know what medications work the best. We know what to expect, and most likely this is what's going to happen in the future. Every child is individual. None of the kids have read our books, but most commonly we can kind of know what to expect in the future. I'm going to give you a few very common epilepsy syndromes, a brief description of them, just to kind of give you an idea how we do this process. There are some devastating epilepsy syndromes, and then there are some that we're like, you know what, not to worry, this is really good. If chances are that your child will be seizure-free in a few years are very high. So this is one of the devastating epilepsy syndromes of young babies. So we often see these kids in NICU. They have other challenges like feeding challenges as well, and they start having seizures very early on, and often multiple different seizure types, but many of them just kind of fast, either tonic seizures, so stiffening, myoclonic seizures, which is quick jerk, or infantile spasms, which is a very particular type of seizure. EEG is always very, very abnormal. So we call it burst suppression pattern. So it's typically brain activity is continuous. There's a beautiful synchronous flow, and the brain cells talk to each other, and there's activation, inhibition, and the flow is constant. But with these babies, there's no activity for a little bit. So the whole brain goes silent, and then there's craziness going on, and then there's silence, and then there's too much activity. So it's very, very abnormal background activity. And we know that when we see this, on a neonate, we know that, oh my goodness, we should do genetic testing and imaging right away, because there are some known mutations associated with these type of findings. So let's see if your child has one of these. So then we know how to kind of move forward and what to do in the future. We want to be very aggressive on treating these seizures, because we know that we give the child the best chance for the best future that they can have if we get the seizures under control. The expectation is that there's going to be multiple seizure types, very difficult to control. Many of my patients with Ohtahara syndrome continue to have several seizures a day, severe developmental delay, often shortened lifespan. So it's a big hit for families. But we kind of want to give you the right idea from the beginning, so then we can offer you the best support from the beginning as well. And we can offer the best chance for the child as well. Another kind of severe type of epilepsy in little babies. So we often see these babies coming in around 3 to 6 months of age. First, they have maybe one seizure. Sometimes EEG is abnormal, sometimes it's not. They come in a few weeks later with the second one. We're like, we'll start them on medication. And then a week later, they are there with multiple seizures. Then we'll quickly kind of rapidly go on 2 and 3 medications, and EEG gets to be very abnormal, and we're often very challenged on treating these little ones. So again, we do genetic testing early on. Often we have several kids who, for example, have KCNT1, that's a potassium channel mutation. And why it's important to know this, it can guide us with treatment. For example, these kids, not only seizure medications, but also particular medications just targeting that potassium channel can be helpful for treating their seizures. So that's why it's very important to kind of put this together. So many times, because I've seen so many of these babies, they come in and I see this particular EEG pattern and the seizure evolution on the EEG, and we're like, get that KCNT1 mutation. Let's see, if we need to get other medications than just phenobarbital and Keppra on board. Often quite difficult to treat again, and quite challenging. But when we know what we're dealing with, then that's very, very super helpful. This is quick crash course for EEG. So this is what I do several times a week. I love looking at EEGs. So in the EEG, we don't look at the direct brain activity under that electrode. We compare how the brain activity looks compared between 2 electrodes, either next to each other, or we can kind of compare to other areas of the brain. What numbers are on the left side? Blue. In my particular EEG is colored blue. Midline is colored blue, so I kind of know where my hemispheres switch. And then even numbers are right. And then each letter has a location on the brain. So there's frontal, polar, frontal, temporal, occipital, central, parietal, and so forth. So it kind of gives an idea where the seizure or epileptic distress is coming from. And this particular one is one of our migrating partial epilepsies of infancy, kind of right posterior head region seizure. The next time she had left, so that's what the migrating, he or she, I don't remember, but that's what the migrating means. Sometimes it's on the right, sometimes it's on the left. So that can be kind of challenging both sides. Infantile spasms or West syndrome, the kids have these kind of clusters of very short spasm-like movements. There's no loss of consciousness, often associated with falling to sleep or waking up from the nap or nighttime. EEG has this very particular classic pattern called hypsarrhythmia. It just means that it's very disorganized, very high amplitude, and there's epileptic discharges all over. We know to be very aggressive with this treatment. Typically, first-line treatment is ACTH, which is a steroid, and it's an injection for about 4 to 5 weeks. There's a few other treatment options as well. We know that if we don't manage this syndrome very aggressively, most of the kids evolve to what we call Lennox-Gastaut syndrome, that I'll touch base a little bit later on. This is hypsarrhythmia. So it's just very chaotic. There's no organization, and it's very high amplitude, very abnormal brain activity. So we measure the treatment success by making sure that the brain waves get to be lower amplitude, more organized, so that we use this EEG data to guide our management as well. We'll start the babies on ACTH, we'll repeat the overnight EEG in 2 weeks and make sure that this badness has been resolved. If it hasn't, we'll just keep on going. We'll just keep on finding another treatment option. Because if we don't, many of the kids go into Lennox-Gastaut. What it means, many of these kids, they have some kind of developmental delay or cognitive impairment. They have multiple different seizure types, typically multiple times a day. There's a particular EEG finding that we see. And why we also want to kind of figure out if we're talking about Lennox-Gastaut syndrome is, then there are some medications that are known and shown to be more successful in treating these patients. So if we see a particular EEG pattern and the history goes along with Lennox-Gastaut, we don't sometimes go with let's start with Keppra and go from there. We'll just say, you know what, we know that this medication will give the highest chances for your child, so let's just go with felbamate in the beginning. Total opposite of the epilepsy syndromes that I mentioned before. But again, very important to put the history and EEG findings together, because that gives us a very helpful idea of the prognosis. So benign Rolandic epilepsy, or BEX, which is one of the most common focal epilepsy syndromes of childhood. The classic histories, a young pre-pubertal kiddo, typical like 5, 6 years of age, can be anywhere between 4 and 10, out of sleep, focal onset seizures. The classic story is that the child comes to the parents' bedroom and can't talk, but is like kind of pointing that something is happening. Sometimes it goes to a focal motor seizure, and some kids do secondary generalized, so have a generalized tonic-clonic seizure as well. Very particular EEG finding on this syndrome. Almost all of the kids grow out of these seizures by puberty. Typically, the kids don't have very frequent seizures. So sometimes when I make this diagnosis with classic history, classic EEG finding, and it's only been focal seizure, I might say, you know what, maybe we don't even need medication. Let's just watch. If your child has just 2 or 3, 1, 2 years apart, we can just kind of watch it, because we know that most likely your child will not have them when they hit puberty or after puberty. Most commonly, the kids continue to be on regular classes, no cognitive difficulties. Some do have some attention issues. There has been some studies showing that there can be very subtle kind of learning or behavioral component as well, but most of the time the kids just do really well at school. Sometimes we'll treat the seizures for years, wean the medication off, and off they go. Another syndrome, I just call it P syndrome. It's just a very difficult Greek name to say, but the history is kind of very classic, kind of preschool age, younger child, out of sleep. And these seizures last for a long time. The kids are pale, limp, they often are nauseous and vomiting, a lot of saliva coming in, and sometimes the eyes are stuck, and they can last like 20, 30 minutes, but don't happen very frequently. So this is also some syndrome that I don't always start medication, even though it's quite long. One seizure is quite long, just because we know that 90%, like most of the 90% of the kids, they grow out of these type of seizures within the next few years, and then none of them have them when they're adolescents. So again, we want to put the seizure type and epilepsy syndrome to a box, so then we can tell you what to expect in the future. Childhood absence epilepsy. This is one of the most common epilepsy types. Little one, first, second grader, multiple staring spells at school. Sometimes we get these evaluations for inattention or hyperactivity, but they happen to have absence epilepsy. So about 5 to 10 seconds of sudden behavioral arrest. So the kids are very active, do something, and then they continue, and they have no clue what happened. They just continue where they ended. Very particular EEG finding. And the kids have hundreds of these per day, so very frequent. And we want to treat them because it's kind of like pushing on and off computer button on the brain hundreds of times a day. So that will eventually affect learning and everything at school. So we want to treat these kids so their cognition stays normal, and they can be the best that they can be at school. Most often very easy to treat, but sometimes we have challenging cases as well. Very particular EEG finding. So not all seizures that are staring seizures are absence seizures. So that's why we're going to confirm with EEG. Similar look, but the seizure started on a teenager. The childhood absence, most kids grow out of it. Teenage patients, very rarely they grow out of it. So even though the history and the look is very similar, the future outcome or expectation or prognosis is very different. So that's why the age makes a difference as well. So then let's go to the basics. Oh my goodness, my child has a seizure. What do I do? What do I do? What do I do? What do you do? You want to do something because it's very nerve-wracking. Rule number 1, stay calm, which is the most difficult thing to do. You don't have to try to stop the movement. Sometimes, there's a lot of jerking and kicking and things. Don't try to, hold or stop the movements. Just make sure that the surroundings are safe. So for example, if a child is, at the park in a swing, maybe you want to take them out of the swing and put them on the ground so they don't, fall off and hurt themselves. Never put anything in the mouth because first of all, your fingers you get hurt, or if you put something else in there. The jaw is one of the strongest muscles, so the child can break it, and then things get into their throat, and that can be dangerous. So don't put anything in the mouth. The child is not going to swallow their tongue. You can turn the kiddo on the side because sometimes there's vomit or a lot of saliva coming out. So on the side position, that's the kind of the easiest way. If you just have them on their back, everything kind of pulls back in the throat. And then, it's very useful to time the seizure. It's estimated that the parents feel like the seizure takes about 3 times longer than what it actually did. So, if you're kind of cognizant enough during the seizure to kind of push the cell phone timer, for example, to see how long the seizure is, that helps us significantly. And also the instructions, when do you have to take the child to the ER or not. And then after the seizure is normal to be very sleepy. We don't want the eyes to be stuck on one side or one side kept jerking for a long time. But as long as the child is kind of, loose and moving and rolling around and kind of answering, but very tired, that's okay. So this is where the timing comes up. So you don't have to take the child to ER every single time when they have a seizure. We'll typically say, you know what? We did the initial evaluation. We have the EEG, we have the MRI, we know what's going on. Now, from here on, you don't have to take your child to the ER after every single seizure, only if it lasts longer than 5 minutes. Now, sometimes some of our patients have these long seizures frequently, so then we do have rescue medications that we can provide for home. But initially, I'll typically use this, only if the seizure lasts longer than 5 minutes, it's a 911 call. Or if there's a seizure that's short, but the child just not coming back in between another seizure or third or fourth, or if, for example, the eyes just keep on being stuck on one side and then, they're jerking and then they stop, but they're not responding and the eyes are stuck and then they keep jerking again. That's concerning as well. Obviously, if there's trouble breathing, that's concerning. I've had patients who, for example, dislocated his shoulder because of seizures. So, pain after, that's concerning. So then you might have to go to the ER just as a result of something that happened during a seizure. Water is scary. So that's kind of the only, one of the only things that I say, like never ever leave your child alone in the bathtub or anything where there's water. If they have a seizure in the water, that can be very, very dangerous and sad. I kind of want to know all the seizures in the beginning, so I kind of get to know the child. Sometimes we know that a particular child has 10 seizures every day, and that's kind of the best where we have gotten. But then if there's an increased frequency all of a sudden, or if there's a new type of seizure that the child has never had, we want to know. Obviously, side effects. Like, our goal is to help the child and stop the seizures. Our goal is not to cause problems with the medications. So if there's side effects with the medications, then that's a time for discussion. Sometimes we'll tolerate some side effects if we have gotten a good seizure control, but sometimes we don't. And then it's just time for either dose change or medication change. This is also a very common question, kind of like, so are there any known triggers? Lack of sleep. If you don't take your medicine, you have a high risk of having a seizure. Older adults, alcohol can lower seizure threshold, or being sick, and so forth. I already talked about water safety. I typically do let the kids cook, but they said maybe use the back burner if you start having a seizure when you're on it, and pull something, it's less likely that you pull it over you and burn yourself. Climbing, don't go to the rooftops or high trees, because if you have a seizure and fall down, that might be dangerous. And then any kind of wheel activity, always wear a helmet. But scooters and skateboards and bikes and all those kind of things, they're typically okay as long as you wear your helmet. So take home points. I'm a little over time. We started a little late, sorry. We want to make sure that, is it a seizure or not? Or is it something else? Epilepsy is when you've had 2 or more unprovoked seizures, or if there's one seizure and very typical EEG finding. We want to know what the seizure type is, if it's a focal onset or generalized seizure. because then that kind of guides us with the management, medication choices, and so forth. And the first goal of all this is no seizures whatsoever. So we don't tolerate once every 6 months seizures like that. That is not okay. We'll just need to kind of keep on pushing if that happens. And then, if you're on the second medication and the seizures continue, then it's a time to see an epilepsy specialist, because there might be something else that we can do for your epilepsy, not only adding the third or fourth or fifth or sixth or seventh or eighth medication, but maybe do something else. And sometimes, what I've done is I've just simplified the medication regimen and taken the medications that actually worsen the seizures off, and then we have a controlled child with particular epilepsy syndrome. So sometimes it's just that, the knowledge of different medications and the interaction in between them, and what medications can worsen particular epilepsy type. So that's important. I think that's it.
Excellent. Thank you so much, Dr. Steenari. I don't know if we did go a little over time, but according to the schedule, there's not a doctor right after. There's 3 questions from the audience if you're interested in answering them.
Yeah, of course. I just opened the chat. Is it
yes,
the chat?
So they're kind of peppered in there. We had some questions about accessing this presentation later, which I answered in there, but the other ones, one was about MRIs.
Yeah.
With or without contrast, what's the difference? And is there a risk in using contrast?
Yeah, that's a very good question. So what the contrast is, it's gadolinium. So what it does, it's put in the child's vein, and during the MRI, they first do the imaging without that gadolinium, and then they do another round with that. And that gadolinium stays in the blood vessels. So first of all, it shows the blood vessels very nicely. But then if there is either tumor, infection, inflammation, something that has disrupted blood vessels, or something that has more vasculature than typical. For example, tumors that are fast growing have a lot of blood vessels. The gadolinium is picked up by that tumor, and we can see it. So if we're suspecting that your child, or if an adult has a seizure, if we're kind of ruling out tumor, we want to use the gadolinium, because that can sometimes show us that tumor. Inflammation, when there's a leaking of the blood vessel, the gadolinium kind of goes into the brain matter as well, and kind of lights up. So that helps us seeing that. I, for example, have some patients who have particular leukodystrophies, which is a white matter disorder, and there's an inflammation in the white matter. So we can see that contrast in there. So sometimes we don't need the gadolinium, but especially if your child is an age where he or she needs to be sedated for the MRI, I typically do order it with and without, just to kind of get done with it. I don't want to sedate the child twice if I then notice, oh, there's something that I'm actually interested in, I want to see it with gadolinium. So I'll typically order that MRI with and without gadolinium the first time, because there's more risks with that sedation. There is some risk with gadolinium too. So we don't want to use that several times, but when we kind of weigh the risks and the benefits, yes, we typically want to add that gadolinium in there.
Excellent. This is a good question too. Does seizure freedom with medication apply to all seizure types, including absence? So if they're still having their staring spells, is that considered seizure freedom?
Nope. No. So seizure freedom means absolutely no seizures. So even can he have like the little ones? No. So the first goal is no seizures whatsoever. So even a 4-second absence seizure twice a day, that's not okay. Now, that being said, the first goal is seizure freedom, but sometimes we'll have to adjust that goal depending on what else is going on. So, you know, if we want 2 medications, or if we're having a tons of side effects, and, you know, we just keep working and working, sometimes we'll kind of get into the, well, you know what, let's just tolerate these little jerks, and then we'll get the big ones, you know, under control. So sometimes we'll have to do that, but especially with absence epilepsy, that's not controlled until there's no seizures whatsoever. Now, yeah, anyways, never say never, right? So there's always, you know, changes in the history, but most commonly, yes, we want all the steering spells under control.
Excellent. I was typing that response, but I wanted it straight from the doctor's mouth that yes, any seizures does not equate to seizure freedom, even if they're little.
Exactly. And can I point out, so I typically ask on the clinic visit, like, not just do you have generalized tonic-clonic seizures and do you have focal onset seizure? We'll kind of go on, like, can you tell me about the events that your child has? So sometimes they call them auras, or little tics, or little jerks, or space outs, or whatever word that the parents are using for that particular thing. I'll, you know, describe all of those, and then we'll go all through all, because I just ask, has there been any seizures? No. Oh, is there any staring spells? Oh yeah, there's like 10 staring spells per day. I'm like, oh, right, okay. So it's very important for us to know, you know, different spell types. So then we actually know if there's still seizures or not.
Yes. Okay, another good question. Would surgery be an option if seizures are controlled with medication?
That's a great question. Now, so there's different situations. For example, if there is a big cortical dysplasia or slow growing tumor that we know is there, and, you know, we have seen the seizures starting from that area, and everything kind of points out that, you know, that's the culprit for these epileptic seizures. Most commonly, we say that we should not move forward with surgery if somebody is controlled to medications. Now, when a child is young, there's more brain plasticity. So the earlier we can make an intervention like that, like resecting the lesion, the better the outcomes later on. So if there is a big blob in there that is causing seizures, we know that it's going to be there forever. We know that most likely the child will be on these medications forever. Then we might want to at least go through the discussion on, you know what, even though you're controlled right now, but the lesion is in a location that we wouldn't cause significant deficits or problems after the surgery. Maybe we want to consider if we want to do epilepsy surgery now when the child is very young, to then, you know, provide as many years as possible, hopefully off medication, and the seizure burden not be there later on. So in quick answer, no, we typically don't want to do surgery if the uncontrolled on medication, but then there's always caveat to that. So then we have a discussion with the family. Good question.
Yes, and then the rest of the questions are just about accessing this presentation at a later time. This has been recorded, and to my understanding, Sophie's Journey, the presenting organization, will be posting this on their website at a later date, just like they do normally in our in-person expo. So stay tuned. They'll probably, to my understanding, again, different organization, but they in the past have posted on social media. Our videos are up. Go check it out on our website. So check their social media, check back on the websites. And on a later date, this will be accessible. So if you loved Dr. Steenari's presentation as much as we all did, and you want to share it with a loved one, that will be accessible later. So Thank you for that question. And then the slides themselves, to my understanding, will be recorded in the video, so you'll be able to access them that way. But yes, is there anything else you want to add, Dr. Steenari?
No, thank you for this opportunity, and thank you everybody for joining, and hopefully we'll see each other, live in Disneyland next year.
Yes, we missed Disneyland, but thank you so much for presenting. Again, as a reminder, my name is Rachel Edasami from Epilepsy Support Network. We're good friends with Sophie's Journey, and so they've asked us to host some of these videos, especially for our doctors that are local. So Dr. Steenari is from CHOC Hospital in Orange County, so Children's Hospital Orange County, and she is an excellent epileptologist